Hello, my name is Henry Silverman, and today I would like to review some concepts in informed consent in the research setting. First, I'd like to go over a few introductory remarks about informed consent. Specifically, I'd like to go over the legal, regulatory, and ethical requirements of informed consent. Regarding the legal history, first, it wasn't until 1914 that we had any legal pronouncements of the issue of informed consent in clinical medicine. Back in 1914, this case, the Slowendorf case, involved a woman who gave consent to have an examination on the ether, her diagnosed fibroid tumor, to be examined and determine whether it was malignant or not, but she expressly did not give consent to have it removed. However, while she was under anesthesia, the physician diagnosed the fibroid tumor as being malignant and removed it anyway, which led the Justice Cardozo to pronounce that every human being of adult years and sound mind has a right to determine what will be done with his body. This case gave patients the right to say yes or no. However, it wasn't until 1957, involving a case in which a patient underwent a spinal surgery operation, and in the post-op period, he fell and became paralyzed, and he contended that he never received any information that this was a potential risk of having that surgery. And essentially, the justice in this case pronounced that a physician violates his duty to his patient and subjects himself to liability if he withholds any facts which are necessary to form the basis of an intelligent consent by the patient to the proposed treatment. So this case established the right of patients not only to say yes or no, but the right to have the adequate receipt of information in order to make an intelligent decision. Regarding the regulatory requirements, the U.S. federal regulations, otherwise known as the common rule, state in 45 CFR 46116, no investigator may involve the human being as a subject in research unless the investigator has obtained a legally effective informed consent of the subject or the subject legally authorized representative. And this informed consent must be sought prospectively and documented to the extent required under this U.S. regulation. The ethical requirement, the history in 1947 in the Nuremberg Code, stated that the voluntary consent of the human subject is absolutely essential. And in 1982, the President's Commission for the Study of Ethical Problems stated informed consent is rooted in the fundamental recognition that adults are entitled to accept or reject healthcare interventions on the basis of their own personal values and in furtherance of their own personal goals. So we see that informed consent has a legal, regulatory, and ethical requirement in healthcare and in most research with human subjects. Informed consent represents an authorization of an activity by the subject based on an understanding of what the activity entails. And it involves a process of reasoned decision-making and not merely a form or just an isolated episode in the informed consent process. Also, I might add, informed consent represents only one of the many ethical requirements for conducting ethical clinical research. So, informed consent, very important, but one of many other ethical requirements. So, how was the informed consent addressed in international codes? Again, we have the Nuremberg Code, Declaration of Helsinki, the Belmont Report, and the SIAMS Report. So we see again in the Nuremberg Code that the first principle and the longest principle states that the voluntary consent of the human subject is absolutely essential. And also in Article 9, it says that the subject should be at liberty to bring an experiment to an end. So these two principles represent human rights in the area of research ethics. The Declaration of Helsinki, authored by the World Medical Association, starting in 1964, and has since undergone several revisions, the last one being proposed in 2012. In their informed consent passage, it says subject must be adequately informed of all these aspects of information before giving consent for the research activity. And they also have a right to abstain from participation in the study and a right to withdraw as well. The Belmont Report, authored in 1979, which serves as a basis for the U.S. regulations, its informed consent paragraph says that respect for persons requires subjects to be given the opportunity to choose what shall or shall not happen to them. And then we have the CIOM's guidelines, or the Council for International Organization of Medical Sciences. In their informed consent paragraph, it states that the investigator must obtain the voluntary informed consent of the prospective subject, or if the individual is not capable of giving informed consent, must obtain the permission of a legally authorized representative in accordance with applicable law. So there are several different pieces to the puzzle of informed consent. First, consent represents authorization by the subject. However, for this authorization to be valid, the subject must be informed, so there has to be adequate disclosure. It's a process, not an isolated event. We'll talk more about this in a few minutes. And in order to be valid, it must be free of coercion or exploitation. We'll talk more about that in just a few minutes. Another way to look at this, the elements of valid consent consist of three major important elements. One, we have to have adequate disclosure of the information. We have to have adequate decision-making by the prospective subject, and this involves that the person has understood the information, is able to reason about that information to come to an expression of a choice. And the third most important thing about a valid consent is that the decision must be voluntary. So we have these three different aspects. So what are the challenges and issues with the disclosure of information? Well, two major challenges regarding disclosure: how much information should be disclosed, and what information should be disclosed. Also, how should the information be presented? Merely in a document, or could we use audio visuals and other types of methods of relaying the information to the prospective subject? What about the readability of the forms, the length and complexity, and issues regarding circumstances and setting of the informed consent process? Well, in terms of what is needed to be disclosed, the U.S. regulations and other international research ethics guidelines mention a concept of the elements of informed consent, otherwise known as the basic elements of informed consent, and then we have additional elements that needs to be disclosed as well, depending on the research study itself. In regards to the basic elements of informed consent, this slide shows the 8 basic elements of informed consent in the U.S. regulations. The first one involves telling the prospective subject the purpose, that the study actually involves research, duration of participation, description of procedures, identification of any procedures that might be experimental, and the probability of random assignment. The individual needs to know that their participation is voluntary. They have the right to refuse and the right to withdraw. They need to know the risks, benefits, potential benefits to them, and the benefits to society, alternatives to being in the study, alternatives to obtaining medical care, issues about confidentiality, any compensation, for research injury and also any compensation just for participating in the study. And then we have contact information. There are 3 types of contact information that the individual needs to receive. They need to receive contact information of who they could ask about questions about the research study, usually the PI or a member of the research staff, contact information regarding questions about research injury, and contact information regarding any questions about their human rights, which is usually the IRB office. Additional elements are shown in this slide, and again, depending on the research study. Challenges in disclosure of information involves how much information to reveal, and so we're dealing with the amount of information. And surely studies, which we'll see in just a few minutes, have shown that informed consent documents have become too long, complex, and do not provide a sound basis for informed decision making. We see the perplexed potential participant with all this different types of information. My apologies for not being able to come up with a cartoon that doesn't have the therapeutic misconception. There's been a checklist that's been authored by the National Cancer Institution, strategies in which you could use to make an easy-to-read informed consent form, and these strategies could be obtained by going to their website as indicated in this slide. Challenges regarding the informed consent setting: what locations would be appropriate to tell people about a study, what locations would be inappropriate, essentially obtaining informed consent in what might be a busy clinic area is not appropriate, does not respect privacy of the individual. Also, there needs to be time to ask questions. Consent is a process. There has to be time for questions, time to discuss with family and friends, and then time to review and further discuss the informed consent document with the member of the research staff. This process regarding time to ask questions may become problematic in research in the critical care setting or the emergency research setting. Also, I'd like to point out that consent is a continuing process. It's an ongoing process. Participants must continue to receive any information that may be discovered during the course of the study itself or from other trials that may affect the participants' decision to continue to participate in the study itself. Also, informed consent is not a contract, as the person who joins the trial could stop participation at any time without giving any reason whatsoever. There's been a large body of information developed regarding empirical research on informed consent. Empirical research on research ethics use evidence-based research ethics. What I like to say is that we actually have facts in research ethics, so research ethics is not just about theory. It is a research enterprise in and of itself. Essentially, ethical principles and regulations tell researchers what they must do, but do not provide solutions to specific real-world ethical problems. And behavioral and social science researchers have the research tools to develop evidence-based solutions. Empirical research is conducted by researchers from a variety of disciplines, use a variety of approaches: qualitative research, survey research, ethnographic research, and much of the research has been on general issues such as factors that affect comprehension of information presented during the informed consent form, but there's also been a growing focus on more complex contextual issues regarding understanding of the risks and benefits, for example, in gene transfer trials. As I mentioned before, areas of investigation regarding informed consent has concentrated on aspects of information disclosure, understanding, and the voluntariness. So what should be included in the consent forms? Studies of consent forms have shown that researchers do not provide information in a comprehensive or comprehensible manner, and there's been poor understanding of what specific information is actually needed by potential subjects to make an informed decision. So more empirical data are needed in order to understand what information should be included in the consent forms. Regarding studies investigating what actually is disclosed, we have one study from 2002 involving phase 1 oncology consent forms shows that we do a good job in giving information about describing the research, the purpose, and the right to withdraw. Not so much that there might be a risk of death. Only 5% mentioned that cure might be a possible benefit. In a study actually that I did with some of my colleagues in a multi-center trial involving the acute respiratory distress syndrome, we looked at the 16 consent forms issued by the different IRBs of the centers involved in this multi-site study, and we showed that only 3 of the 16 consent forms contain all of the elements required in the U.S. regulations. Another study showed significant information was missing from consent forms. Regarding how information is disclosed, there's been studies showing involving readability of the consent form, and shows that the reading level is high at the 11th grade reading level. What should the reading level be? Well, it should be the reading level of the general population, and studies have shown that the reading level of the general population is at the 6th to 8th grade reading level. So the 11th grade reading level is obviously too high. Studies have also shown that consent forms are too long, and in the last several years they have increased in length. What about investigators' practices regarding informed consent form? One study showed that investigators did provide a copy to read, gave them an opportunity to read this before coming to the clinic. Consent forms, 75% of them did provide a great deal of information. Less than 56% emphasized the aspect of randomization, and less than 10% had a formal assessment of understanding. I'll talk more about assessment of understanding in just a few minutes. So summary in regards to disclosure, consent documents usually include relevant information but are not always regulatory compliant and are long, complex, and written at a high level. What about studies looking at understanding? Areas of research include factors that might affect understanding, how and when should understanding be assessed, and how much should subjects understand, and what happens when subjects don't understand. Factors that might affect understanding are shown in this slide. We've got age, severity of the illness, educational level, cognitive capacity, participants, familiarity with the research, and issues involving language and culture, and literacy levels. What do participants understand about the purpose and the nature? One study showed that only 30% of the trial participants thought that treatments were unproven. 80% of Thai participants knew the study purpose, and 100% of subjects in a rheumatoid arthritis randomized controlled trial knew that they were in a medical experiment. What do participants understand about risk and side effects? And these studies shows variable understanding of risk and side effects of the trials in which the subjects participated in. What do participants understand about randomization? And essentially, all these trials shows poor understanding of the randomization process by the subject participants. Formal understanding. Some have recommended the use of formal assessment tools that are shown in this slide. However, instead of using a formal assessment tool, one could just ask the participant after you've disclosed the information 5 simple questions. Tell me in your own words what this study is all about. Tell me in your own words what you think might happen to you, what you expect to gain, what risk you might experience, and what are your alternatives or other choices or options to participating in this research study. When should we assess understanding? Do we need to do this in every research? Well, the short answer is no. We should assess understanding, however, when we are targeting individuals who might have an issue with comprehension. For example, a study involving people with mild schizophrenia or mild to moderate dementia, or a study involving critically ill patients. So, in summary, regarding research involving understanding, understanding is variable. Most subjects seem to know that they are in research, but they research methodologies, for example, randomization and the concept of placebo, are poorly understood. Well, what about voluntariness? Are participants able to make a free choice? Is there a lack of coercion or undue influence? And again, let me remind you that coercion is a situation when the participant will be in a, or they think they might be in a worse off situation if they say no to participation. I'd like to point out that it's very difficult to measure the extent of voluntariness of potential subjects. Influences on voluntariness are shown in this slide. People in dependent position, difference in power relationship, pressures from others, blinded, trust in the healthcare provider, restrictive choices, for example, restrictive choices regarding healthcare, the presence of illness, and the presence of incentives that may act as an undue inducement. In terms of understanding the extent of voluntariness, data on the refusal rate might be used as a measure of the extent of voluntariness. So if you have a moderate to high refusal rate, that may indicate that people actually knew that they could refuse. So we have several studies with a somewhat lowish refusal rate, and then other studies that have a moderate refusal rate. And again, a moderate refusal rate may indicate that people actually knew that they could refuse. What about data involving whether participants knew that they could quit? And these studies show variable understanding of whether participants knew that they could quit. What about aspects of voluntariness? We talked about issues of the therapeutic misconception in the previous module. So if people are under the therapeutic misconception, one has to doubt aspects of voluntariness of their decision. So in summary, regarding voluntariness, voluntariness is difficult to define and measure. Individuals do refuse to participate in certain studies. However, many in other studies do not feel that they could quit. There's been several studies looking at strategies to improve the informed consent process. There was a meta-analysis done of studies involving multimedia components, involving audio tapes, videotapes, and interactive computers. Only 1 of 12 studies showed significant improvement in understanding with multimedia strategies. The other studies showed no significant difference. And hence multimedia may be more appropriate for certain populations
and it may have some unrealized potential. The question is when multimedia would be useful. Other studies or other strategies, or other studies involving other strategies involving a so-called enhanced consent form, a modified style in format or length, and 6 of 15 studies showed significant increase in understanding. Also, increase in understanding occurred when there were extended discussions with a team member or a neutral educator, and also enhanced understanding occurred when there was the presence of a test or feedback. So, summary of different strategies. Studies of new approaches and interventions to improve consent form have had mixed results. Shortening the form shows more promise, and personal interaction more important than the written communication. So is an informed consent broken? Gail Henderson wrote in an article that there's been too much emphasis on the form and not the process. Inadequate understanding of the difference between research and treatment, meaning the therapeutic misconception, and inadequate understanding of research methods by the potential participants. Conclusions: informed consent in research is imperfectly realized. Data suggests consent forms are long and complex. Understanding is variable. Many participants do not know or feel that they could quit. However, spending more time may enhance understanding. More rigorous data are needed, and also quality training of researchers, research team, and members of the IRB. Thank you very much.